Welcome to Innersight, Health Optimization with Rudy and Shaun.
Right, here we go. Shaun, podcast number 18. Great summer's day in Cape Town. And I think it's a good time to go into our movement podcast, our first of the movement podcast. We talk about our four pillars of fitness, and we talk about stability, flexibility, strength, and then endurance. And without our guests' today's expertise, we would not be moving at all.
Yes, I think movement is so important for longevity. So we need to keep that movement. And we hope to learn a lot today on what we can do to keep our mobility and hip health. So we've got the expert in here today. And by chance, it's your brother.
Yeah.
You won't say it. I don't see the resemblance, but...
Yeah, so I'll introduce him. I've known him for obviously my whole life. He's a little bit older than me, but we look almost like twins these days. So Dr. Hennie Bosch is an orthopedic surgeon, northern suburbs of Cape Town. So Hennie studied at Stellenbosch here in Cape Town. Also then specialized as an orthopedic surgeon, then super specialized as a hip and knee arthroplasty surgeon in Wales in the UK. And recently he's done the MSc in healthcare transformation from the University of Texas in the USA. So his main focus is the hip, and that's why he's here today. So welcome, Hennie.
Thank you. Thanks for giving us the time. I know you're quite a busy man, so thanks for coming out.
It's only a privilege, and I'm quite happy to share my passion around joints, movement, and so it's just a great opportunity to just share my passion. So yeah.
So we're going to try and keep it in the middle ground. So there'll probably be pieces where our colleagues as medical doctors will understand a little bit more, and then we would also really like our audience that's layman in the medical field to understand. So maybe just for the people out there, just give a brief anatomy of the hip, how the hip fits together. I know it's a ball and socket joint, so maybe just so people understand where it sits in the body and why it's so important.
Yeah, so from my side, I think it's the center of the body. You need the hip for everything. And the hip really affects you if you're really in pain there. So it's a ball and socket joint. You have on both sides. The human person is the only one, and the specific muscle around it. We learn a lot more about this, specifically for upright stance. So small things which people don't know is that the human person is the only one who's got an iliotibial band. No other animal has that, and it's quite an important structure. And that's and the iliotibial band is kinetic type of chain, so it's like a elastic, and that's where the mobility is very important. You actually need weaker muscles as long as the kinetic chain is well nutritioned. Anyway, the hip itself actually has interesting stuff around it. We know different things about the shape of the hip these days, and that can preempt you arthritis in the hip as well. So if you can address these things and pick it up early, you can address that. The hip labrum is a big thing. I get a lot of referrals to see the labrum or see labrum tears, and we fix that these days with arthroscopic surgery.
So I think that's quite interesting. So I think so we've got the hip. We know where it is. It's a ball and socket joint. The femur sticks inside, and that's where we actually carry our weight through onto the pelvis. Maybe let's try and speak about, because I mean, hip replacements is actually the surgery of the previous century. It was said that that's actually the operation of the previous, and maybe we should talk about that, because I mean, such a big part of how you got to what you're doing is hip replacement. And maybe let's pull back from hip replacement. So you get hip replacements because you fracture a hip. So maybe we should just talk about hips, the healthy hip. What things can you do to keep your hip healthy?
So just from there, just with the fractures and the non-fractures, is that we have to really look at this, because people associate hip osteoarthritis and osteoporosis. It gets confused always. So when you have weaker bones, you have osteoporosis, and it tends to sound the same. And osteoarthritis. So in the layman, you get confused. So osteoporosis will give you fractures. You normally can get a fracture in the wrist, in the spine, and in the hips. But in the hips, it's quite detrimental. It's very expensive for the medical system. And then the osteoarthritis is where we get wear and tear in the hip. And that's a different one. But both are treated with osteoarthritis at the end. So I think, so we talk about hip health, osteoporosis.
Yeah, so but that is towards the older people from 65 plus that we see both of those conditions more often, or do you see some of that at the earlier stage as well?
Yeah, we do see it at earlier stage. It's more endocrinal problems, parathyroid, things like that, which affects your calcium absorption, surgeries which can cause that, so on. So it depends on, and then certain medications as well. If you're long-term on cortisone treatments for organ transplants, all these things, rheumatoid, those things, they can also get more osteoporosis as well. So yes, osteoporosis in essence is that you don't get enough, or your bone mass is actually less. So we look at it as a bank. So you can put things in your bank, but if you don't put things in your bank, you will have less of it. So it's important. Yes, the problem starts at a later age, but you can do a lot. You basically have your physical bone mass at the age of 35, and then it's actually starting to drop. But the most important thing is to build into that bank. And to build into that bank, you have to keep mobile, so weight-bearing exercises. Specific, actually, yeah. So it's interesting. A runner can also get osteoporosis because it's not just one sport. So the idea of multiple type of sports, not just a cyclist, it's been associated. You think, okay, it's just if you're cycling non-weight-bearing exercises, you can you will get more osteoporosis. It's been now shown not to be. Actually, there's a big study now in Australia which they've just showed that people are actually just taking more senior people and building their bone mass just by doing some kettlebell lifts. So that power is very important, and loading onto the hip. And the idea of actually explosive type of things like jumping can help, but then on the other side with fractures, the risk of fractures, you lessen there. So that's then the exercise part. Then you must look at your absorbing more calcium. So calcium into the body has to be converted via vitamin D3. Otherwise, it's not active. And that's the main thing here. So it's part of, you get vitamin D3. We don't get into the sun these days. If you go out in the sun and you put a factor 15 or anything higher on your skin, then that doesn't convert D to D3. I think you've recently also said you must sit a half an hour in the sun a day, but if you can't, like me, I'm in theaters, I pop my D3s, and that's very important. So then that's the nutrition part.
I can tell that most of the clients that we test is low in vitamin D. We need to supplement almost all our clients with vitamin D.
And then another thing is that the whole thing of the HRT, that whole myth that people which should not get HRT, the main thing with hip fractures, it's much more common in ladies because they go into menopause, and you don't have estrogen, and then you actually, that's not good for bone health. And then also the males, later age, so fractures at the age of 85 is actually not great. So talking about these fractures, and that's why should I do all this, is if you get a hip fracture, your chance of mortality in the first 30 days, and that's after the age of 65, is 5 to 10%. And then if you have on the other side of and then in 90 days, that's also 5 to 10%. So in 10% chance that you'll die from a hip fracture within 90 days. And 20 to 30% that you will die from a hip fracture within a year. So the big thing here,
That's high aim.
that's very high. So it's like a myocardial infarction, and it's preventable. And the best preventable is mobility, active walking, be busy, and look at your diet.
Yeah. Yet again, you need to start early and build up and prevent things like that. It's a compounding interest type of theme. We need to do more when we're younger.
Yes, exactly. And that's just the bank. So if you think of a bank, which you can put in small things and you can get the whole compounding thing. You couldn't have described it better.
Okay. And I think hip fractures operations are pretty sorted now. That hasn't changed much in the last few years. But what has changed quite a bit is then the other part that you said, not osteoporosis, but osteoarthritis. The arthroplasties where you actually have a hip replacement, that has changed.
Yes. So I think hip replacements, and I thought, I mean, they've said, what is the operation of the century? So you just said it was the one of the past, but it's actually been coined the operation of the century as hip replacement. And you say, why would you coin this operation as a century? Why? I thought it would be cataracts or something like that. But because you can give people's mobility back, you give them their function back. And we actually are, and I have patients like that. I never thought it was possible. And that's our big dream and the whole thing. And the hip arthroplasty idea is to get patients to a forgotten hip. So you do a hip replacement and you walk up to a guy a year later and say, which hip was done? And they don't know. They can't immediately tell you. So that's the level which hip replacements has changed to. The problem is that it's also been initially, the hip surgery was done by everyone. And so the function wasn't expected. We just wanted to take pain away. But the risk of dislocation, all these things. So now you have an easy approach, cut muscles and do this hip replacement, and anyone can do it in any town. Or you can level up to a place where you can do a hip replacement, which people have a forgotten hip.
Shall we just go step back there a little bit? So go through muscles. You're talking about the posterior approach, where they go through gluteus muscles, or what do you refer to?
So there's three different approaches. So the big one, the most common one was the Harding approach, which you lift up the gluteal muscles to go into the hip. The posterior approach was then a better one in the way that you don't cut muscles, but then it also was deemed to have a higher chance of dislocation. Understanding why dislocation is that the ball of the hip replaced hip is smaller than the normal one. The smaller the ball, the less the wear. Then you get longevity. But now our plastics and everything has changed, so the ball is now get to an average of about 32, where traditionally it was about a 28 and even 22s. But a 20, so that's just the size of the ball. But now we know about how to put this thing in, so the dislocation rate is much less. We get restore the center of rotation and get this hip to be feeling normal.
So adjusting the technique has given us all this improvement.
So this muscle, and then the approach, which I in 80% or 90% of cases use, is now the direct anterior approach, which we don't cut muscles. So it's a shorter cut, but it's not about the length. It's just that you don't do soft tissue damage. You literally don't cut any muscles. You only cut the capsule, which is the lining around the joint. That's all you do.
And hence why they recover so quickly.
Yes, yeah. So we are now sending patients home the same day after hip replacement. So that's that. But the nice thing is the fast function, get back to mountain biking, all these things, doing Cape Epics, those type of things you can do with a hip replacement.
That's amazing. So, and I think what we're trying to say is this field is still moving. So we've talked about the fractures, which before we studied medicine, people used to be in traction and could not have the hip repaired, and you can now repair hip fractures, but you can also do hip replacements. So I think what we should maybe move to, because I think our listeners are more people that are younger, screenings, and I think that's a part of where you live these days, is trying to fix hips early to not get them to have OA. Because and I think maybe if we talk about the anatomy again, that hip is under vacuum, and I think that's maybe something you can start talking about, why that vacuum is so important.
Yeah, so I think for me, that's where my whole history started. I came back from my fellowship, and then suddenly I really focused on hip resurfacing, which is a different type of joint replacement, mostly in males and so on. But anyway, long and the short is it's a specific segment which you service in that case. But then I was trying to focus on young adult hips, and that's the typical ones I think your listeners tend to be the cohort of. And this is where suddenly I was the guy now, or we started basically in South Africa as a group of guys looking into this. And it was actually in 2003, I went to Bern, and there was this whole thing described as femoral acetabular impingement. And what it means, basically, you have a cup and you have a ball. But the cup can change with certain things. You have either tight hamstrings or you have a hollow back. And then you can change it dynamically. Or you go and do strange sports. I say you either have an abnormal hip in the way it's shaped that way, or the femur, which is not all the way around. So we know when people start training a little bit too early in the youth, that where the growth plate is not changed, you can get a full slip of the femur at the growth plate, or you can get a subtle one, depending on the load while you're still in your faster growing phase. So the shapes changes, and then you also have a genetic component. And that is now been described as a hip, or it's been described as a cause of arthritis. So now we know this can cause arthritis, and we can address that. We can pick it up, and then we can really prevent it.
So you want to prevent the arthritis?
Yes. So what's now happened is we has this hip arthroscopy in 2006 when I started. It was, what are you doing in the hip? So the first thing is to just understand that we can get into a hip, but a hip is a closed joint. So we let people sleep and we can pull on that hip, get a centimeter space and work inside it and fix things, put sutures in and reshape the femur and the acetabulum. But understanding also address the soft tissues now around it. So we're not only working inside, we're now working outside, right around the hip now. And we can address clicking hips and all these things. So that's what I do a lot of.
So just for our listeners out there again, so what we're talking about is that you're a youngster, that a hip, there's a problem being picked up, and now they're putting a camera inside the hip and operating via camera. So 2 little, 3 little holes, and you can actually see and work in there with tools. So and with that, it's minimally invasive. You actually don't have to dislocate the joint or anything like that.
Yes.
So obviously, later on in the disease with arthritis, they present with pain. But now we're talking of a client or patient that arise before they've got that disease. What type of symptoms do they come to you with? How do you, what do your typical patient, what do they complain about?
So there's a lot of times the people go to physiotherapists and all this, but I normally had a groin pain. I typically describe it as the C sign. So it means you try to grab your hip in the front and the back at the same time, but your hand is too small. That's a typical C sign. And then you can get this groin pain or the bum pain and stiffness. So you battle to put on your shoes and socks, stuff like that. And this pain is interesting. You have that type of patient, and then you also have the one with the soft tissue problems. Typical runners. I've got this typical segment of a runner, which is, they're fine. They can walk with you, they can do anything, but they're going to run, the next day they're painful. They go to the physio or bio or chiro, and the next moment they'll be treated for a psoas problem, hip flexor problem. The next moment, and then they will rest it. The next day, they will have a piriformis problem or a glute problem. So you've got 4 muscles around your hip, which is motors, which try to stabilize it. So if you've lost your suction in your hip, then one of these muscles sometimes get angry. And it is actually, those muscles can just last 25 minutes. So you typically see the fast runner, they get their pain around about 25, 30 minutes. It's about, depending on how fast you run, 4 kilos to 6 kilos. They typically like that, and then they can't run. And then they rest 2 days and they're fine again. And they go on like that for 2-3 months, but they don't get better. They do physio, everything, but they want to run. Just operated in the last month, 2 people who's done the comrades earlier this year, typical thing. Because what happens is you stretch your capsule as well. So you tear your labrum first, and then you stretch your capsule. And that can all be repaired with this hip arthroscopy running again. I saw a girl this today, and she said, "Will I run again? Can I run?" I said, "Yes. I've got a really stout patient, and I don't think she's after the hip arthroscopy is won the Kona, which is the triathlete at 49 years of age. She then went on and injured it again, and we did the surgery again, and she won again the Kona at the age of 52.
Yeah.
So, and the Kona is the Hawaiian triathlon. It's the world championship. She is the world champion. So you can get back to that function. The problem is you have this groin pain which you nurse, and you get to straight it, but you can't get back to that sport. And previously, before we did the surgery, people couldn't detect it. We couldn't pick it up on MRIs, and then we couldn't do anything about it. So prior to 2006, If you had that problem, you had a scare, we had to send you to a psychiatrist and say, you're crazy, you are faking your symptoms. And I have a lot of patients sitting in front of me say, please tell me there's something wrong, because I know there's something wrong, but no one can pick it up. And sometimes even the MRI doesn't pick it up, and then we do a diagnostic and therapeutic operation, and we find the problems there, because not everything is on pictures. It's a functional problem.
So, and just to understand again, you talked about the capsule. So the capsule is the covering that keeps the juice inside pretty much to make it glide. But then you have the labrum, which is, you've got one in the shoulder and you've got one in the hip. It's pretty much to keep the suction. Have I got that correct?
Yeah, you got it right. The labrum in the shoulder is actually just helping with stability, like for overhand type of activities in the front, that type of thing. But it's not giving us the suction. Okay. And the interesting thing is, and that's the difference, the shoulder is not a weight-bearing joint. So the cartilage needs feeding in the hip under pressure. So I said the labrum is like a sluice on a dam wall. It keeps higher pressure on the one side. And the cartilage needs to, which weight-bearing cartilage needs to feed like when you put a piece of sponge in water. If there's enough water in the bath, it will fall out all the way. If it's just half, it will not fall all the way. That pressure is needed. You need enough of that. And if the labrum is torn, you lose that pressure. And there's a lot of nutrition in the joint fluid. Mm-hmm. So that needs to stay there. The capsule is just there for stability, but in the hip it's important. So we previously did hip arthroscopies and do a capsular release to get a bit of space there to work. And we've actually realized that we as doctors are harming patients if we do too much of a release. So a lot of our work now is in that phase, and sometimes we would even turn the bones to get them at a happy place. So it's a long leg, weight bearing, which is dynamic and needs, as we call it, a center of, you need to have the whole thing aligned to bear you. But it's interesting that you will have strange shapes, but the whole combination can give you a lasting joint.
So interesting.
So if you, let's say an athlete, you hear on the news, like one of the NFL guys had a torn labrum, and so I presume then there are certain sports that are more, the incidence is more in certain sports, or is there something that people do that they tear their labrum more, say?
Yeah, so I think the whole idea of having your hip stability, so the kinetic change, or your core of your hip trained or not. Now, most athletes have that trained to a certain level. The layman of someone who's just going to start training and you're going to start running and you want to do the 12-week program and run a 10K or 21K, those people are the ones who injure themselves. This whole thing of hormesis of you get a stimulus to a certain point and you gain, and then you go too far and then you start to damage yourself. So with the sports, what you see is rotating and debending type of sports. So if you think of it, you say hockey, you can't say hockey. You can say hockey goalie, because he goes into a squatting position and rotate on that and jump with his legs in certain ways. Then you see that person. So you must really, so a ballerina, splitting. If you are a lax person, you'll split there anyway. But you can stretch the capsule, but you can damage your labrum. So the idea, what a lot of people understand, is the labrum doesn't tear on one occasion. It's a repetitive stress, which it at some stage just give. But there's a lot of load. So a lot of people come to me and say, why only at 42? I've been doing this for so long. I said, but you've crossed that part which it had too much load. And then it gives.
I suppose if you have, like any sport, you get a little bit of damage, but you need time for repair. And if you don't give enough time for repair in between, then it's just a cumulative type of process.
Yeah, the idea of load over time. So if you load it too much over a short time, and that's also where you have a genetic thing. So when we look at people who say, all right, you have a genetic cartilage which you were given. So with respect, they always say it's like tires. You get either a Chinese tire or a German tire, and that's genetic. But then you can decide how you load that tire. Too heavy, or am I going to give it segmental loads? And that's where I sometimes just say, it's like a taxi. or taxi driving people. If you put a lot of people in it, it's heavy, it will wear. And if you're either going to drive a lot of distance with it, and that's the thing. Now, the distance is not a problem, but a lot of distance over a short time is going to cause much more wear.
Yeah, so you need the adaptation to actually prevent that. And I think that's often the case in many of the things is that people want to do the 12-week fitness program, but it should be a lifelong thing, and you should do it gradually when you start.
The problem there, Shaun, is that with running and with a lot of training, we get a lot of endorphins. So it's really, and we get a lot of, and specifically running, if you want to feel better, look better and so on, it's a quick fix, and we're in a quick fix world. And that's the thing. Specifically, if you've gone through your teenagers and you start to train now in your 30s, 40s, you're kind of at that place which you want to, had your babies and you just want to be, again, active. You have actually suddenly have time. You tend to overtrain then. And that type of midlife crisis times. And that's what we see. We see those patients, which tend to do too much too soon. And then also the people who tend to ignore their problems. And then they come with already a worn hip. So I sit with that patient, say, listen, if you came earlier, I could have done something more conservative. Now the question is hip arthroscopy is how successful it is. And that's quite nice, is that I've said initially we started off, we looked like the cowboys. Now where we are now is our society, the International Hip Arthroscopy, has had a name change. It's called the Hip Preservation Society. I joined that in 2009, and I think around about 2017 our name's changed. So we've been shown, and I've had a lot of patients 10, 12 years on after hip arthroscopy, some of my colleagues as well, which is, they don't have arthritis in their hip yet, and they should have had it within 2 years if we didn't do it, in a lot of them.
Impressive. And I think, so if someone is out there and they have, like you always call it, the deep gluteal pain or pain around the hip, what would you suggest? I mean, not seeing you straight away. So physio, bio, or what would be the first steps for someone out there?
I think the main thing is to understand the hip pain. We talk about groin pain, but people don't know where the groin is. I have a lot of people who come to me and say they have hip pain, and then they put their hands where their pants is, because that's the clothes maker's hip, where your belt is sitting and then pointing at the back. That's not your hip. So your hip is when you move down and you feel on the sides of your body, and you feel that two hard bones. If you put a kind of hand breadth of 4 fingers to the front, that's your groin, there where you bend. If you have a pain there, then that is hip pain. If you have a little bit higher, then you can have hernias and stuff like that. But that's where you get a hip pain. What is very interesting is a lot of people will sometimes present with knee pain, but it's actually coming from the hip. There is a known referred pain, which is going to the knee. And people have had knee surgeries, but actually coming from the hip. And you will get these crackings behind the kneecap and so on, we call patellofemoral syndrome, which is associated with a hip labrum problems. So if you just not address the knee, so the knee surgeons send those patients also to me. So the main thing is a thigh pain on the side. What I know is a hip does not pain below your knee. That is not common. There is one thing which can cause that, which we call ischiofemoral impingement, where you pinch your hip at the back and pinch the nerve at the back, which radiates down, and it will mimic sciatica. But it's like less than 1% of my cases we see that. So then the pain on the side is a very interesting thing, which people tend to ignore, and this is the big thing of trochanteric bursitis, which is also something we can talk about.
Yeah, so in general terms, if you get someone that shows signs of hip pain or groin pain, most likely they're either doing too much over too short period of time. So the first step would be to either tone down a little bit, speak to someone about your form in the sport you do, and see if that betters it. If that doesn't better, then you need to see someone like yourself before you. Or I suppose most of your referrals comes from the physios.
Yes, so that or other specialists, so colleagues of mine. So in that way, but what I think is important is there's two types of patients depending on what your level is, where you are. Did you enter for a Comrades or a Two Oceans marathon, whatever? You need to know, can I do it? Not, I've spent money, that type of thing, or how should I rehab? So at least if you have a diagnosis, so some of them just gets into me. We make the diagnosis and say, this is it. This is our conservative route. And then if the conservative route fail, we will continue to surgery.
Do you then have a specific group that you work with for the conservative treatment that you prefer, or is it?
Yeah, so I believe in an integrated practice unit. So yes, we have, but we've also know, and you pick up that there's, so I get referrals from Namibia till the Eastern Cape, basically some up to northern country as well. So we know our people which we would send to us or where we send our patients back to. And I think, over the years since the lectures was there and this whole this coaching around it, because we all had a learning curve in it. There is people who specialize in it, and I think this is the place where we are these days. I mean, orthopedics itself. I mean, I started off we could do anything. Now these days we all focus on a joint because orthopedics gives so much back to mobility and actually changes people's life to the better. I'm quite excited about that, but it's also just how much it's grown that we can have in my hospital 8 orthopedic surgeons and all can service the community.
Maybe I want to get back to, you said about conservative. So that's a step before you do an operation in a hip. So I know you inject into the hips with the ultrasound, and how does that work?
Yeah, so if you think of any hip problem, it's like you can either say it's inflammation or there's cartilage problems. So what we know is that at this stage, there are different things which we can inject into the hip, but you can also take supplements for your joints. We know that the MSM, chondroitin, glucosamine, and also very important, I think you've done a study actually on it about collagen and vitamin C, that you can take as much collagen as you want to, even for your face or whatever. You will not use it if you don't take any vitamin C's extra. You need to give collagen, vitamin C's, otherwise it will not grow. So yeah, from my side, the injections I'll discuss. So I like to give joint supplements specifically after surgery when the joint capsule is closed again. And in this hip arthritis category of patients, we can inject hyaluronic acid and some cortisone as well. You can either have it done by x-rays by the radiologists, or I use ultrasounds in my room. It's just I get feedback immediately and it can help. We also use PRP. PRP is called platelet-rich plasma. And what it actually means is we draw your own blood and we spin it off at a certain rate and get then the healing cells in there. And in the bigger terms of medical is that we know is that you get the healing cells there, but it's actually the second messenger system. If we have got the medical students, they will understand that part. But in layman's terms, it calls the healing cells to that point. What is interesting in the trochanteric bursitis ones, since 2019, there's some nice studies out of that, and I've been using it since then quite often in the bursitis.
That's the PRP.
PRP.
Okay.
So it's been shown that cortisone to PRP, so cortisone to PRP, in the non-inflammatory patients, which doesn't have rheumatoid and those type of things, the PRP is the better injection for the bursitis and subtle gluteal tears. The thing is that people should not take anti-inflammatories with that, but it works really well. So that's platelet-rich plasma. So that's the injection there. In the hip itself, we can also do the PRPs and also inject certain muscles with the ultrasound around the hip, like the hip flexor if it gives pain. And it helps us with diagnosis as well, because we can mix a local anesthetic with that. So sometimes people have a hip pain, MRI is too expensive, you want to buy them time. I just saw a guy now, he has osteoarthritis in his hip, and his medical aid is only going to be active in 3 months' time. Give him painkillers, or can I inject him in the hip and buy him time for 3 months? There are people who've got heart conditions, are too afraid of hip replacements, or have to go and visit their family somewhere. So we have these things as well. It's a nice arrow to shoot, and it works really well. And it's really just that gels which we inject now has developed so much. And what's nice also with it, that since it's done at volume, the prices is coming down as well. So it's coming affordable. And actually some of these injections we can do under the hospital plan of certain patients. So it's not costing me a lot of money. So it gives us a lot of value. And that's where I like this idea from Texas as well. Look at value where we can add to people's lives without surgery.
And so I want to come back. So we in our anatomy, we didn't talk about the bursa. So the bursa sits outside the hip. So you said about the ITB or the iliotibial band, and that there's friction there. And have I got it right? The bursa sits there, or
yes. So the iliotibial band is a sinew which runs from the side of your hip wing, there where your belt sits, to the side of your knee. And what happens is sometimes you don't have the strongest gluteal muscles, or you have a tight iliotibial band. So what can cause tightness? So I have this philosophy of inside out, outside in, or inflammatory causes. So the outside in is people who have knock knees or flat feet, develop flat feet, or actually have a cause of tight ITB, leg length discrepancy, post-fractures or stuff like that, scoliosis, that thing. Then that ITB spans over that area. Then you get a type of ischemia, or actually, if we say ischemia in layman's terms, it's lesser blood flow to that area. And then that bursa gets thickened and actually doesn't roll as it should be, and you get these pains. Or you sleep on a hard surface. People believe they should have a hard mattress and actually sleep through. If you are very lean, you can push directly on it, or you fell with your bike and you get a direct hit there on that area, get inflammation and bleeding in that area. Now this bursa, it's nice in Afrikaans, a beursie, but in English it's a bit different. So I say it's a pocket. And if you think of it, when you bring a boat onto the land, you have these rollers. It's a roller. It's filled with fluid and it rolls. And this bursa then gets irritated, but then the secondary underneath that is the gluteal muscles, which is kind of like your pillar of your whole leg when you walk. And then that gets sometimes subtle tears or even pulled all the way off. And then you walk with it. You look as if people say they feel as if they walk with their foot into a hole, or they're limping, or they walk with a flat tire. And you can look at people. A lot of people have that limp. So you either can have just the muscle tear there. So it's a degree, bursitis. Then we get the micro tears. Then we get the macro tears, which can be repaired. But then also, if you have a labrum tear for a long time, problems in the hip, that's the inside out. And I've seen it now, a third of patients which actually have these bursitis, they get injected and they don't get better. There's a problem actually inside the hip. So when we we can fix it either with open surgery or with arthroscopic surgery, put anchors in the bone, pull that muscle back and get them back to life. But then just watch quickly inside, or go and watch quickly inside the hip, and you find the problems there, the original cause. So sometimes people are not even aware of their problems inside the hip, because it depends on your activity level and what you demand from your body.
It always amazes me that, you get a symptom like pain, but there's so many muscles involved, so many moving parts. It's sometimes difficult to pinpoint where the problem lies. So it's quite impressive that you can do all these things these days to help people out.
So if we talk about the younger patients, so now you've injured your hip, you take a little bit of non-steroidal anti-inflammatories, you go to the physio, and the hip stays sore. What's the time span that you think people should have a type of pain? If it doesn't resolve, when should they see someone?
So if I sit here, I say I've recently had a 17-year-old lady. She had a hip arthroscopy, fixed the labrum, and she's fine. So suddenly she developed a pain. On the other side, she came to me, typical teenager, said, listen, fine, we do the scan, because she wants to go on a camp or something. Did the MRI, found the labrum tear. She wants me to fix it. I said, no, wait. The labrum can heal between 6 and 12 weeks. I cannot do surgery for you if you haven't gone through that. You're a young person, and that's the thing. So we know labrums can heal 6 to 12 weeks. But if you have underlying cause like a dysplasia or a big pincer type of thing, then listen, this one is possibly not going to heal. But I think from my side, is conservative route is always the best. And that's 6 to 12 weeks. I give up to 6 months. I think that's a fair time. I can tell you categorically, I've done close to 3,000 hip arthroscopies, that a labrum or a hip which hasn't been better after 6 months is not going to get better. There's an intervention necessary. There's some 2 big studies in the UK which they did and compare long-term conservative treatment against hip arthroscopy for femoral acetabular impingement. It was a randomized, controlled, multi-center study with orthopedic or hip arthroscopists who can do the surgery and physiotherapists who were trained with specific certain level. They are hip physios. And both studies came out that the surgery is better than the long-term arthroscopy. And that's a year later, if you compare surgery with that. But saying they didn't do the surgery in the first month, they also did the conservative treatment. But then if you say, listen, I'm not going to come for surgery, I'm going to go. And the main thing which you must understand, it's a functional problem. The shape of the femur needs to be addressed, or the acetabulum. It's a pinching hip.
Okay, and I wanted to ask you, the femoral acetabular impingement, we in our practice as normal doctors see that on x-rays these days and their reports, and they talk about femoral acetabular impingement, which is a big part of your work. So if you can just maybe say how that works, because the femur and the acetabulum, so the acetabulum is the bucky, the where it fits into the cup, and then the femur. But where does it impinge? Where's the problem?
So most of the impingement happens in the front of the hip, and I think it's in some way we are protected by the good Lord that all the surgery is in the front, because there's a big nerve at the back which we cannot really work too far at the back. So it's normally bending forward, and what we see is that people will actually, with the femoral one which doesn't fit, so it's an asuricity of the femur head rubbing on the inside of the hip, and that rubs away the weight-bearing cartilage. But then after that, you can get a contracoup which it will pinch on the backside, and that's why people get the deep gluteal pain. So the hip doesn't fit, so we can reshape the femur head. It's not the whole head, and certain people just have it in the front. So when you look at the x-ray, it's nicely round, but you look at it from the side, and that's why we like to do a done view on the femur head there, and we can see that on that the shape of that femur, which is not great. What I've seen these days is that sometimes some of these things get over-reported on x-rays as well, and then the GPs needs to refer them and so forth. I don't think they have to refer everyone. They have to look at the symptoms. The biggest thing is if you can bend your leg to your chest and push your knee to your navel. If you then get a groin pain, that is an impinging type of pain. That, and if you sit cross-legged, like I said, like us males do, when you put your ankle on your other kneecap, you push that leg down and you get a pain on the front, not in your lumbar spine at the back, but in the front. That's 2 tests which I can do on a Zoom call with a patient and actually tell them they have impingement or not in the hip.
Okay, I think we should maybe go through that again. So you pull up your leg to your chest. That's the one,
and push the knee then to your navel.
Okay,
up to navel.
Yeah. And if you then experience a groin pain, that is impinging sign. And the other thing is if you put your knee, or your ankle on your opposite knee,
yes,
and you put your leg down, and you also feel a pain somewhere in the front around your hip, not at the back, because that will be a SI joint test as well. But that's 2 things that you can do. It's better to lie down on a bed while you do that rather than sitting up, because you want to stabilize your back when you do that.
Okay, that's amazing. So you can actually do so much more, and it's been developed pretty much in the last 20 years that you can actually move to not have a hip replacement, and those patients ended up with really bad osteoarthritis early, and and then when you do get osteoarthritis, because I presume if we live long enough, most of us will end up with osteoarthritis, or is it not a given?
I don't think it's a given. I think where medical field is going these days is that our cartilage and things which we do. I mean, I go into a hip and see full-blown cartilage problems, and I have a collagen membrane which I can put in that space where there's just a small cartilage damage. So if you think of an apple which you hit and there's a bad piece on that apple, we can remove that and I can patch a piece of membrane in there. I've recently started just taking some of the good cartilage around that, which we then mix with the PRP patch or gel, which we actually just spin further, and we will glue it back in that area. So things is happening at a very fast speed. So I don't think that we can say that we will never not. So if we can get the shape right, and now there's ways which we can now map the hip while we operate, and we can determine where the places is exactly pinching, so just taking off the necessary. In my surgery, it's technical. If I take too much bone away, then I lose the suction seal at a different age. So I can do a perfect round hip, but I lose the suction seal. So the hip should be fixed according to. So we do test it dynamically for that specific patient. Now I've done enough, I've got the skill, but the younger guys are now learning it as well. And now we get all these aids which can help us to do the surgery better. And so in that way, we can have then preventative surgery and not having arthritis. And then it's all about what tire did you get? Did you get a German tire or a Chinese tire?
Yeah, and I think the one thing you said there is there's aids, and I think while we're talking about aids, we should maybe touch on the robotic surgery. So that's also coming in now. It's mostly knees, or they do lots of hips now. I'm not 100% sure.
So the robotic surgery is for hips and knees, and the shoulders should be shortly. The robotic surgery, I think, is to get surgical precision and actually rule out outliers that you can actually. And what also helps is that we can actually now just not put one hip replacement or knee replacement for a patient and help us to position our prosthesis in the perfect place. I think it helps us when we are low volume surgeons that it can actually get us sooner to a better point. And everything in life, if you don't measure, you don't know. Saying that, it is expensive. So now you must always play it against the value. Because in a country like us, you have a 4-year waiting list in the state for hip replacements. That takes a little bit longer. Is it worthwhile? So I think if you're in a pinnacle, you're always pushing that. But we always, as orthopedic surgeons, are now battling with the value in this whole thing. Longer in theater, a little bit more expensive. How much better results? Is a robot going to give us a better results or not? Or we're going to have an experienced surgeon? And it's all, at this stage, a bit cloudy, but there is place for the robots. I've used some of it in the hips. And in the hips, it helps you with a bit of leg length, and it also helps you with the position of the cup. It can be very technical, so I don't think it's at this stage like the prostate surgery that you needed to have it done that way. But I think I can't say it's wrong, but I think it's coming and it's actually improving. It's helping with the knee replacements now that we have already identified 4 segments of where to change the positions and that everyone else just having in the same place. So what we like is that we get data of how the surgery is done now, and actually it's going to help us improve for later. So it is the future, but it's. I think if your surgeon don't offer it, there's a reason why not. I think.
I must just listen to the reason, and if it's good enough, then you pick your surgeon, and that's quite interesting because you hear that in general talk these days. But my surgeon is using a robot, and it's good that you said, but maybe for the lower volume surgeons or for certain specific surgeons that they like using it, but as you said, a bit more money and a bit more theatre time. And for some people, that makes a difference. For being under anesthetic for half an hour is probably not good for them, like the hearts and stuff. Yeah, interesting.
The jury is still out, but I think every time when we're in a congress, that's always the discussion. And I think at this stage, there are, if we look at arthroplasty companies in South Africa providing it, half of them are providing it and the other half not. So if you have a business decision that you're not giving it, you make a decision if it's valuable or not. So it's not that every company has it. And that should tell you as well.
Yeah. Interesting. Yeah. And talking about value, so we listen to previous podcasts and they talk about, speak to your surgeon about their numbers, because that's the next thing is you're quite data driven. So you follow up and you use the Harris Hip score, and how does that part of your practice work, the data? And
yeah, so I as surgeons always have tend to have quite a proper ego, and I guess you have to have a bit of a narcissism to think that you can cut on someone and make them better in that way. And at that stage, you always you tend to be competitive. You want to compete with either someone next door or with yourself or something. So how fast can I do a hip replacement? How fast can I do a knee replacement? That whole idea. And then the next thing is, oh, I've done 20, I've done 100, I've done 300 or whatever. And I remember that I was sitting in a congress and I sat with one of my colleagues, which I respect a lot, and said, how many of this have you done? I said, so much. He said, but so how do they do? Because if you can do 500, you're just possibly a nice personality or a nice salesman. Or you can just chat people into operation. What is your results? So I then invested in software and really started looking at that, and it's patient-reported outcomes. Respecting that some people don't want to, and then from that you can learn and actually analyze that. And the nice thing now is that I've got more than 10-year database. And we've really tweaked it now, and the whole thing of the Value Institute is looking at totally that, to say, look at what you've done and change small things to get marginal gains, but it affects your patient. And then you start measuring. So we always measure now stuff, orthopedics, how good we are. My patients is so many days out of hospital, my hips length is this way, the rotation, I don't have so many dislocations, that type of things. And the whole thing now with the Value Institute is now, which we spend time and say, but no, we want to know how good the patient is. So we want patient-reported outcomes from the patient's environment, not from us. So now we suddenly go and look at the psychological part as well. Because a knee replacement and hip replacement is not good treatment for depression. You'll have pain and depression. And then a knee pain, which is not that bad, is then very painful. And you do that in hip replacement, and they're not much better because you treated the hip and not the patient. So this is where it really comes to the next level of being a real doctor and treating a patient in his whole environment. Yeah, so that's where that whole thing comes. The problem with it is that it's a big barrier to start off with, because you're now suddenly not taking your money and put it somewhere else and put the money where you're going to have a nice inheritance and stuff like that and a nice trust fund. You're now investing in this to have a better thing for your patients. Now, as the one surgeon, it's quite expensive, but I think I saw the value and I've learned a lot from it.
No, that's a very nice approach. And also patient-centered. At the end of the day, it's all about quality of life. So if you've done the surgery and you don't get the quality of life, the patient doesn't get the quality of life, then did you do him a favor? So I like that approach.
I think the main thing for us as orthopedic surgeons, or also as doctors, is we have that part of our oath which say, first do no harm. And how do you know if you've done harm or not? The problem with orthopedics is that such fast turnover. You see a guy, you do surgery, do a hip replacement, they're better. Within 3 months, you don't see them. You follow them up once a year. But now I get my data. I've got 4-year results already on more than, I think, 800 patients post-hip arthroscopy. So you can say to patients confidently, this is how you're going to do. You're not giving someone else's papers. But then at least you also know, listen, I have done harm here. I didn't help this patient. And then you can say, okay, but the diagnosis is wrong or whatever, but then you can at least learn from it. So at least the next patient down the line is not going to be worse off. Nobody's perfect, but we try.
I think that's amazing, and I think we're running a little bit out of time. So I want to take the whole picture. So we took one of the big joints in the body today that we know can have problems. The nice thing is there's quite a lot you can do, so you don't have to just genetically, if you have problems, that can be fixed. But then also with diet, you can do a lot with certain strength exercises, flexibility, and the hip can keep you mobile. I think that's a nice thing.
I think if I can just add that, I think we've skipped one thing, and if I can add that to patients, we didn't talk about some exercises. Now, according to me, if you can really want to get your whole lower leg, the alignment, everything good, it's either how you stand, what your feet's mobility is like, or your hip. And the most important muscle in the hip is that gluteal muscle. And that gluteal muscle needs to be exercised. And if you go and look at people who are older, they walk more and more with bent legs. They're not locking their knees. So if you can concentrate when you walk that you lock your knee, push the knee back, then you're actually activating your gluteal muscles. The less you activate your gluteal muscles, the more you bend your knees, and you will become a fall risk and so forth. So if I can leave that, say, lock your knees when you walk. And check people out when you look at the shopping center, the people who are not locking their knees. And then do your exercise of your gluteal muscles. The Jane Fonda, you can Google Jane Fonda, gluteal muscles, iteratia. Just that exercise, just that one, I think, is a good start.
That's great. So that's the other part is, I mean, you don't have to just know it. There are people out there that actually, so the bios and the physios that now also specializes in hips. So you have these certain pockets of people that can help you. And I think the next part is that if there is problems, you can get help early. So that's the other part. And after, if that still fails, then there's different new techniques that you can get your hands on or your hip on as a patient, and that's still moving. And then new medications. I mean, it's a fascinating field.
I mean, my takeaway is that I didn't realize that you can make such a big difference intervening early and prevent the arthritis and prevent certain things of happening. And so much has changed recently that it's amazing. I'm just trying to figure out in 10 years from now, this might feel like historic, and it's amazing at the speed where we're moving towards in medicine in general and new techniques and things like that. But moving back, that we need to make sure the base is good. We need to make sure you've got that base to work from so that you keep it for longer. So when new techniques arrive, that you actually can get it and you're not already down the drain.
Yeah, I think for me, my big slogan in life is to move is to live, and to live is to move. And that's what I want my patients to do. That's what I want to do. And I think the whole thing of move, keep on moving, take steps, and you will have a good bone health. And yeah, that's what you also want to do. Or what you actually, that's your big message. And I love that. And that's why I'm here today.
Great.
Hennie, thanks for coming. I loved it.
Yeah. And thank you so much for taking time off. I know it's a busy schedule, and it's a lovely day out there. You could have done something else, but I think there's a lot of our listeners that's going to get a lot from this. So thank you very much.
It's only a pleasure. Thank you, brother. Thank you, Shaun.
Thanks, Hennie. Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.